Okay, so how far? Here? Which, oh, here with him? Okay, you're sure. Absolutely. Okay, so we're better off. We're better off in here? James Bond? Here? Okay. You go in there first, so then you'll have a really good entry. Because I'm gonna, you're there, no, after I introduce you, you come here. You go there first.
Okay.
Yeah, I'll introduce you first, and then you come here. So there's like a drama. Are we starting? Oh, he's leaving us with that already? Or not yet, right? Should not be. Is that the purpose?
Oh, it looks like we already have it.
I should be here.
on.
Oh, is it already recording?
Yeah, because it says in stream.
Oh,
I think
okay.
It's a live recording.
And we are visually in there already?
Right? Because the only button is a red button that says in stream. So I'm gonna assume that it is.
That we are good. Okay, I think that's what it is. Come on in. Should we start now? I think we should, right? Ashlyn, is your advisor here? Dr. Shra is. Okay, so we can start now, right? Well, good afternoon, everyone, and welcome to the second session for this afternoon symposium. Our presenter for this afternoon will have a degree in biology with concentration in medical sciences. He is a Floridian native from Winter Haven and has been at SEU for 4.5 years. While at SEU, he served as president of the Pre-Dental Waxing Club for 1.5 years and was a member of the club for a year prior. Was a part of Ghostlight Theater for 1 year and has been a member of the Student Christian Medical and Dental Association for 2 years. Upon graduation, he plans to attend the National Institute of Health Post-Baccalaureate Research Program for 1 year and then attend dental school to obtain a dual degree in Doctor of Medicine in Dentistry and a doctorate in philosophy. Please welcome Mr. Jorge Torres.
Good afternoon. My name is Jorge Torres, and I'm presenting on skin and the efficiency of practicing in oral on the suboptimal. Oral cancers are diagnosed about 50,000 diagnoses per year for oral cancers, with about 7 likely being diagnosed in men. The most common oral cancer is both squamous or carcinoma. As you can see here are the prerequisites of the cancer. This cancer is found in the 4 areas of the mouth: the lips, the tongue, and the tongue. In the last 10 years, there's been about a 10% increase in survival rate, 46% in 2012, and in this year, for 50%. Now, there are multiple factors for what this is. If due to age or simply just immunodeficiency disorders, multiple different viruses can enter the stuff into the body and cause cancers. However, the most largest factor for all of this continues to be smoking, about a 78% increase in people who smoke. Now, what are some symptoms of all of these? As you can see, these are 2 pictures of erythroplasia and neoplasia, which are basically prerequisites of the cancer. It's not the actual cancer yet, but it's basically the factor preexisting for the cancer. Now, some symptoms include pain, trouble swallowing, slurred speech, and if it's metastasizes, it can affect the nervous system as well as inspiration and digestion. Now, what are some treatments for all of these? For early stages of OTC, surgery seems to be one of the biggest treatments, and they should also focus on keeping the functionality and the cosmetics of the patient. Obviously, don't want a big hole in your mouth. Why it's early stage when the tumor is still small. Another treatment for early stages of OTC is the radiotherapy. Again, it's very important to keep functionality of the mouth in question, and as you can see over here, the machine they also use for it with radiotherapy. For our later stages of OTC, chemotherapy or using chemical drugs is always used. However, its toxicity seems to be one of the biggest issues with this treatment. Now, for my study, capstone, I'll be focusing the first aim will be increasing the taxane drug by using gold nanoparticles. And for the second aim, it will be decreasing the toxicity of the drug. Now, what is taxane? Capecitabine is basically a powder drug of 5 aerosol. You can see here we have a we also the chemical formula of the drug of aerosol to capecitabine. Basically, it helps us be able to overcome multiple factors in the mouth, as it's a form of fertility, which in this case allows for 5 aerosol to be given to patients orally, as the capecitabine enters the body and becomes 4 aerosol after a couple of different steps. Now, these drugs are the anti-metabolites. They're basically drugs affected of nucleotides, specifically for capecitabine and for aerosol to affect the pyrimidine synthesis. Now, obviously, it's important to look at the toxicity of the drug. The capecitabine includes the hair loss, as many of you have probably seen patients with cancer in their hair, as well as erythrocytosis, which is basically swelling, pain in the hands and feet, what is also called hand-foot disorder, not to be confused with the childhood hand-foot mouth disorder. Now, obviously, also there's some changes in behavior. For example, there's skipping issues, there's pain, there's changes in the habits of eating and drinking. As well, there's due to the drug, there's always affects the extra blood. One of the biggest one and capecitabine being leukemia, which is affecting the nutritional of the body, also affects the immunity. Now, gold nanoparticles. Gold nanoparticles are still a novel treatment in cancer research. In the past few years, it's been used in cancer. For example, using cytoplasm targeting and nuclear targeting peptides can basically affect the cycle of the cancer cell, the cell growth, as well as it regulates cycle, causing accumulation in the S phase and a decrease in the G2 and M2 of the cell. Also, there's been previous studies using gold nanoparticles and aerosol has been successful. However, it's not been used capecitabine, which is the aerosol. Now, obviously, if any kind of treatment is important to add the toxicity of gold nanoparticles. And that is still novel in cancer research. There's still very little findings in toxicity. For example, there is a study that focused on mice, and they found that 8% of the blood being toxic dosage and 1.6% being toxic dosage. However, in experiments in mice, it was very minor changes in organ. And the study also said that humans have lots of cover. Still novel, if time goes by, we'll probably notice more issues than I read. Now, my study. In my study, I will be grabbing 38-week-old CA mice, which have been genetically changed to be able to be given or N2O, which is the cancer chemical. These mice will always be, make sure to be consistent, they will be 25 grams, and after 40 weeks, they'll hopefully have a tumor. We will have 4 treatment groups. We will have a placebo group, a group with the gold nanoparticle solution only, the drug, capecitabine, and then the combination of gold nanoparticle solution and capecitabine. In the first 4 days, we'll be giving the mice group 2 and 4, which is the solution and drug. We're giving them gold nanoparticles and personality, which is medicinal heavy. While in group 1 and 3, we're giving the same solution in order to be placebo. Once again, here is the chart of all the different treatment groups. The next few weeks, we will be giving the mice group 1 and 2 was placebo and inclusion only the placebo. This will be 1250 milligrams twice a day, morning and evening, for course of 3 weeks. Now, for the drug activating once more, it will be given 1250 milligrams twice per day, morning and evening, for 3 weeks. So for 3 and 4 with 50 drugs and for 3. Following those 3 weeks, we'll be giving a 1 week rest, and we will repeat the cycle of 4 days of the gold nanoparticles and 3 weeks of the drug for course of 4 times, 4 cycles. For the treatment group. Now, from first aim, increasing the hepcidin efficiency. During the study, we will be basically measuring the tumor growth. But after the mice have the tumor growth in the for the week, we'll measure the tumor. After the once weekly, we will be measuring the tumor growth, it is an increase, decrease, and if the study goes well, we'll be hopefully seeing a decrease in tumor. We'll also look at expression of biomarkers for cyclin D1 and adaptive. I think they're both important biomarkers in cancer. As there is a higher increase in expression of cyclin D1 and a decrease in expression of cancer. Now, this study is the result goes planned. We will be decreasing expression of cyclin D1 and an increase in expression of toxic cancer. Now, for second aim, we'll be focusing on decreasing the drug toxicity, which obviously we're paying attention to the mice hair loss, looking at their feet and hands for any kind of swelling or pain or swelling or any issues. For behavioral changes, we're focusing on looking at their sleep, if they have any expressions of pain, any changes in the habits of drinking or eating, as well as we weekly testing their blood, see any changes in the blood. Now, why is this study? As a study, we're focusing very much on hepcidin, which is, as of right now, not used as a cycle for uracil. So it's very important to look into using this eventually. Also, as I mentioned, it is a oral approach of uracil, which allows it to be orally, so and it's also looking into gold nanoparticles and hepcidin combination, which has not been tested before, especially not in OCC. Now, for future studies, it's very important to look at how to use the drug of hepcidin, as well as comparing the type of results, especially in OCC, as well as more studies in gold nanoparticles, which, as I mentioned prior, this is still a very novel treatment in oral cancer. Very important to also look at the combination hepcidin, as well as just know what we and possibly looking at early stages, but as of right now, it's probably not a good idea as well as just first testing of any interactions that may occur between hepcidin or the nanoparticles. This might increase the toxicity of the drug or toxicity. Obviously, acknowledgement, I want to thank God, Professor Adams, who's my advisor, Dr. Amy Franklin, who is the dean and the professor of capstone course, as well as the faculty at SCU, and especially the biology professor. These are my references. Thank you.
All right, it's open for questions. Any questions? Yes, Dr. Salvatore.
What ratio would you propose for the gold nanoparticle with your drug? How does that work?
Ratio.
Your gold nanoparticle and cap, whatever it is.
Yeah.
You combine them together as one of your studies, right?
I'm giving for each cycle is 4 days of inclusion, and then there's 2 weeks of drug.
Are they together? The gold nanoparticles and the drug
Combined? Yeah, no, it's not.
Okay. What is the mechanism of action for gold nanoparticles?
If I remember correctly,
How would it be delivered to the site?
15 weeks.
If
peritoneum, how does it get to the oral cavity?
Of the arm? How do you get as much of that?
So,
On the, substance.
so you have in your experimental setup, you have gold solution,
What kind of particle?
gold nanoparticle solution, and nanoparticle. No, you have different treatments. You have a gold, you have a nanoparticle, and then you have the gold solution. Yeah, you have like, and then your control. So okay, simply, what is the difference between the gold nanoparticle solution and just the nanoparticle itself? What is the difference in your setup, in the setup of your gold nanoparticle solution and then just the gold nanoparticle? How is that different? Differentiated in the making of the experiment, like in your prep? Yeah. What's the difference? Yeah. I mean, you have 4 different things. They're not the same, right? So how is gold nanoparticle solution different from gold nanoparticle with capecitabine?
Typically, if the only gets placebo, or if only gets
Yeah, we kind of know that. Yeah, just the two. Like, what's the difference between the two? Mhm. Then why is that called gold nanoparticle solution? No, it's not. It's a different treatment. So a nanoparticle is actually a delivery mechanism. So you have the nanoparticle, you actually put the drug on the nanoparticle. That's how it gets delivered to where it's supposed to target. So it's a targeting delivery mechanism, right? So you actually put your capecitabine onto the gold, onto the particle. And then you let that particle get delivered. And the whole purpose of it is so you have very slow delivery mechanism, because the biggest side effect of non-target delivery in cancer is that it affects many different parts of the body at the same time. So you are trying to cure, but at the same time, you're also doing damage to a lot of the parts of the other parts of the body. And so that is the main purpose of this, is you have your drug actually is being placed onto the particle. You actually have that in there, and then you get that into the delivery. And that's a very valid question, because if you're usually, when you do target delivery, because it's targeted already, you want that directly into the part. Like if it's the heart you're targeting, put that into the heart, right? Like, so if it's the mouth, like why do you have to go into intraperitoneum, right? Because intraperitoneum is like you're in the digestive system. Why do you have to go there when it's like right there? It's like, let me just inject that there. You know what I'm saying? Like, so that's the essence, I think, of what you're trying to do here, right? Yes. Okay. Any other question?
What is the gold nanoparticle end? Very end. Of the liver. And side effects from gold nanoparticles? As I mentioned, right now with cancer, this is not many. There have been many different effects. So it's still kind of novel in cancer. Mentioned that they use micro studies, and they did find they use a top dosage and not top dosage, and in the top dosage they only found smaller changes, but it wasn't very like large. Some of them now is still very novel in that. So that moves by into like the actual.
Any other questions?
So I'm just trying to understand what the last question you were asking. Would it not be a good idea to do the nanoparticle solution by itself, just to see if there's a side effect from it?
Well,
cancel it out for when you
so-
combine it with.
Well, so the thing is, when you have gold as a liquid than as a particle in itself, it's a totally different property, and the absorption is totally different when it's in the blood already. So I've never heard.
How did you get the gold particle? with the nanoparticle?
Yeah, what he's trying to do there is that this is actually a nanoparticle without the drug. That's what he's trying. That gold nanoparticle is like,
It's been used by.
it's still a nanoparticle, not a solution, really.
You're right.
Yeah.
Because we need to test part of the gold nanoparticle.
Yes,
Yeah,
without the drug,
okay.
just the effect.
And then again, I mean, I used to work in nano stuff, so
Mhm.
we would coat nanoparticles with something that would allow them to dissolve in solution.
Yeah, absolutely.
But
Yeah, you
if you're
you
doing
pegulate
that
it.
And you were talking about just attach the drug to the surface, then.
Yeah, that's the whole point of the nanoparticle. Yes, is the whole point is target delivery.
And that stopped me from, I don't even know that. Yeah, attaching. the
Yeah, so
nanoparticle.
what you do is before you pegulate, so it's the peg that you actually will coat the nanoparticle with so that it's easy to get into the blood, for example. So you coat that so that you don't also get everything into your nanoparticle. So you put your drug first, so you have to have a linker. You have to have a linker from your particle to your drug of interest. So it gets into the particle and then you coat that because you don't want that also interfered with anything else that it gets delivered in the body. And that's the whole point of that, which is, I think, that's a good thing. He was just not able to like express it very well, but that is a good design in there, right? Because you have the gold in itself. The problem, well, this has been tested in many different things, many ways, not your capicetin, but it's in nanoparticle delivery is now like one of the things. But that is the biggest also dilemma with this is what do you do after with the gold? Gold is metal, right? Like we've used many different types of particles already. In fact, we're doing now organic particles so that it becomes much better because hopefully the body, but still, when it's something that your body is not making, it's still going to end up to be an alien thing that your body will respond. And that's why it responds a lot like inflammatory things because it's, especially with this, it's gold, it's metal. Poisonous to the body, depending upon, of course, the amount.
Like red blood cells and
Yep. Yep.
Risk benefit
Right.
decision.
Yes.
It's
Yes.
risk
It's a risk benefit analysis at the end. Yeah. Just like radiation. Radiation is radiation is still bad, but maybe you can live 10 more years than die of cancer right now. You know, like just like anything else. Yeah. So, yeah. All right. We're good? All right. Okay, thank you, Jorge. Our next presenter is definitely not the last, not the least, the last for this afternoon. Um, she will be graduating with a degree in biology with concentration in medical sciences. She is a Southern Belle from Dallas, Texas, and has been at SEU for 2.5 years. While at SEU, she is a multi-potentialite, being a Dean's List, has been a TA for physics, a team lead for production for the Department of Spiritual Formation, a business data management intern, and participated in the Lakeland Regional Research Residency Program. Upon graduation, she plans to pursue her master's in medical science or continue in research and go to medical school in Texas. Please give it up to Ms. Ashlyn Vallejo.
Put it in presenter. Hello, everyone. My name is Ashlyn, and I will be discussing the potential effects of diabetic therapeutics for the prevention of Alzheimer's disease. Yeah, I am. Oh, okay. Okay, so the objective will be implementing diabetic therapeutics for women, postmenopausal women who are predisposed for Alzheimer's disease and obese, slow down the pathogenesis over a course of 10 to 20 years, as well as significantly decreasing obesity. So, what is Alzheimer's disease? It is the sixth leading cause of death. It affects 6.7 million Americans with a 1 in 9 chance of inheriting it. It is a multifactorial disease that targets the central nervous system. This negatively affects cognitive ability, motor skills, language, and attention and recall. Metabolic dysfunction accelerates the pathogenesis of Alzheimer's disease, and limited treatment methods have been proven effective in preventing Alzheimer's disease due to the lack of understanding of the pathology. But what we do know is that aging is a factor, and through aging, we see menopause in women, which can increase inflammation. And through this, there is unwanted weight gain that will increase adipose tissue and increase insulin resistance, as well as type 2 diabetes, which will again have an effect on inflammation and negatively affect cognitive function and an increase in beta amyloid deposition. So diabetes and Alzheimer's are very similar in pathology. However, they are different. In diabetes has beta cell dysfunction, which causes insulin resistance and leads to further metabolic disorders, and it increases adipose tissue. And signs of Alzheimer's are amyloid beta plaques, loss of neuron function, and neurofibrillary tau tangles. But they both are age-related. They both have an increase in inflammation, insulin resistance, altered insulin signaling, and oxidative stress. Insulin plays an important part all throughout the body. It is widely distributed in the central nervous system. It maintains glucose homeostasis by inhibiting glucagon, and it has potential neuroplasticity effects due to metabolic regulation that can increase cell metabolism as well as neuron function. It can access the hippocampus, which affects memory function, the prefrontal areas, which can tell you when you're full, and hypothalamus, which is the release and regulation of hormones, and the fusiform gyrus. So the way that GLP-1 works is whenever you digest food, it goes into your small intestine. It will release a signal to your brain saying that you have just eaten, and to release insulin to inhibit the production of glucagon. And a GLP-1 agonist will adjust the receptors and increase insulin production. This can positively promote insulin signaling, regulate insulin resistance and glucose uptake, and can promote neural growth and synaptic plasticity. There are other environmental and genetic factors that play an important role in the pathology of Alzheimer's disease, one being apolipoprotein epsilon 4. This is the best indicator for Alzheimer's disease because it can be tested through genetic testing. ApoE is a mediator for lipid and cholesterol transportation. ApoE isoforms alter the structure of neurons, reducing plasticity and signaling, and can also increase amyloid beta plaques. And women with a single ApoE4 gene display Alzheimer's disease pathogenesis, whereas males must be homozygous for ApoE4 for increased pathogenesis. And this can be because of menopause, which is the depletion of estrogen levels and the depletion of sex hormones, which can affect the brain glucose metabolism. Estrogen is a key regulatory factor in the immune system, especially against inflammation. So as you can see on the left, the premenopausal control has a higher brain activity as well as higher glucose metabolism. And through menopause, you can get an increase in unwanted weight gain, which has negative effects on the Alzheimer's pathogenesis, which can be measured through the waist to hip ratio. This is the uneven distribution of body fat, otherwise known as central obesity around your waist. It is strongly related to health outcomes. It can accelerate Alzheimer's pathology in the presence of APOE4 due to the sensitivity of metabolic dysregulation. So as you can see in the picture, you'll take the circumference of your waist and the circumference of your hips, and you'll divide the two, and you will get 0.90 or less in men will be considered healthy, and 0.85 or less for women will be considered healthy. But for women, it varies due to the varying of body types. Current treatment methods, FDA-approved treatment methods have been proven highly ineffective in later stages. Cholinesterase inhibitors can increase acetylcholine for communication of nerve cells. However, it is highly toxic. Antibody-based immunotherapy lowers toxicity levels by clearing amyloid beta plaques, and NMDA receptors encourage cell survival, but they only treat the symptoms and not the disease itself. So again, a reminder, we'll be implementing a diabetic therapeutic. So the specific aim 1 will be to measure the progression of weight loss in patients who are, again, predisposed, obese. And then for the specific aim 2, we'll be measuring their cognitive function. So for method specific aim 1, a total of 50 women between the ages of 45 and 60 who are predisposed with Alzheimer's disease and have a waist to hip ratio above 0.90 and a BMI within the range of 30 to 39. The experimental will take semaglutide, a diabetic medication that regulates insulin levels and weight loss. It'll be administered once weekly at home on the same day each week, and the control group will receive no treatment. For specific aim 2, we will be measuring, we'll be doing a screening every 6 months for the deposition of amyloid beta plaques via PET scan. We'll be doing an MDRS scale examination, and we'll be measuring insulin levels to check the complete metabolic panel with A1C every 3 months, and we'll be measuring hormone levels considering menopause. The projected outcome, we would potentially improve the quality of life and delay death for those who are affected with Alzheimer's disease. We'll see regulated insulin levels, a loss of 5% of body fat over a 6-month period. A waist to hip ratio would hopefully be below 0.80 and a BMI within 25 to 30. Improved cognitive function, improved overall quality of life. And for future, we would like to thoroughly continue the study of menopause effects on neuroinflammation, see if modifications can be made to increase permeability across the blood-brain barrier, and the complete involvement of insulin resistance in Alzheimer's disease pathology. Resources, acknowledgements are to God, Dr. Shaw, Dr. Franklin, my family and friends, and questions. Yes.
Why did you measure estrogen levels?
Well, longitudinal studies have not been done for semaglutide yet, but in some studies, it negatively affects males' sex hormones. So they have a depletion in that, and it affects their fertility. And some women have reported that they have irregular menstrual cycles. So it is important to account for.
One of APE4, does that automatically mean that has
No. There are additional environmental factors that play a part in this, and it can be actually avoided if you live a healthy lifestyle and get good sleep and eat and, you know, increase exercise.
What would you say is the biggest limitation?
Probably the lack of longitudinal studies, so we don't know any long-term effects, but we do know that it can have an effect, potential effect of pancreatitis and thyroid effects, as well as issues with the GI tract. Yeah.
You said there was a 1 in 9 chance of inheritance?
No, of developing Alzheimer's disease.
Okay.
Yeah,
Is that
sorry.
accounting for, like, is it tend to run in families kind of a thing, or is it just a 1 in 9 chance for everybody?
I think it's just a generic statistic. I'm not really entirely sure.
There's no genetic basis at all?
No,
Really?
there is.
Yeah,
There is.
I thought
Mhm.
you mentioned that. So there
Mhm.
is genetic basis, right? You can
Oh,
either be a
yes.
carrier-
Okay,
that's
yes.
what
Sorry. Sorry, I was confused.
Yeah, I wasn't sure if you were saying like 1 in 9 get it or carry it or whatever, or like 1 out of 9 people that have whatever genetic part of it get it or not.
Mhm.
I guess the question is, how much is a contribution environmentally acquired compared to genetics?
Oh, okay. So the environmental factors are very important for the pathology of Alzheimer's disease. But if you do have an APOE4 gene, you can have one or you can have one from each parent, and that will increase, I think, by 30%. I'm not entirely sure, but I think 20%. It increases to 20%. But again, then the metabolic dysfunction and insulin resistance and inflammation can play a very important part in the pathology.
Okay, so if you have an APO, does it progress with age, the expression of the symptoms of the APO or Alzheimer's? Does it start like slowly and progressively, the expression of that gene,
Of the
of the
gene,
symptoms that you will be having? Yeah.
I believe it would be age related as well. Yes.
Age related.
Yeah.
Okay, so that being said, with your sampling, because what's your age size?
45 to 60.
So what's the predisposition levels? And how are you going to determine that your patient is predisposed to
It would be
disease?
through genetic testing to see if they're positive for
what if
APOE.
they're environmentally acquired? How are you gonna, because you said it can be environmentally acquired, it can also be genetics, yes?
Well, the study is going to focus on postmenopausal women, which is why we have done that age range. And then it's also going to be who are predisposed with APOE4.
Yeah, so the
Who are
question
positive.
is, how are you gonna determine the predisposed, right? Because predisposed can be genetics or can be environmentally acquired, because you said you don't have to have the genes, you can also get sick with that. So if I have these patients and I'm going to like, okay, I'm gonna choose 50 out of you, and my baseline is what? What is the baseline of the APO?
My
As a
inclusion?
judge to, yes, by inclusion,
Okay.
like, okay, you have because you have this much level, or you're not included because you have too much of the APO.
Well,
What's the baseline?
my inclusion would be they have tested positive for one gene.
So it's genetics only.
Yeah. Well,
What happened to the environmental? Because you said it's like 9 out of whatever in the population, right?
I could take both into consideration with the design of the study, and I could take measurements of them both and see how they're correlated.
Under testing, you mentioned in the study, what are the amyloid PET scans?
Yes.
See that start giving indication of disease, no disease, or some disease, and track that.
Based on previous studies already, what's the onset more or less? As far as this age group, 40, 45, like on the average, like what is the onset of the symptoms?
It is in your 60s, or late 60s
40
for
is
Alzheimer's.
actually early,
Yes.
kind of an early.
Mhm.
So if you manifest on that early on, you definitely have something in
We're
there. Because
hoping
40 is kind of
to then.
still early from the
Yeah.
more usual onset.
Yeah.
Makes sense. Any other questions?
Probably increase their daily exercise, change their eating habits. If they're pre-diabetic, then they're not diabetic yet, so they still have time to change that.
What about the GLP-1?
I don't think that pre-diabetic patients typically take. Well, I know that the drug is administered for diabetic patients, not necessarily for weight loss itself.
Any other questions? None? Well, I guess we are done. Thank you, Ashlyn.
Thank you all so much for coming.
Thank you. Good job.